Good evening, everyone. Today, the topic of presentation is hypokalemia. So, we see a lot of cases of hypokalemia, especially during the summer season. We see a lot of cases of hypokalemia that can be due to diarrhea. Some might be due to the renal losses of some might be due to diuretics. You need to understand how do you approach a case of hypokalemia. That is very important. So, we go ahead and start with the case-based approach. How do you approach a case of hypokalemia? So case 1, a 34-year-old male known case of asthma was put on salbutamol nebulization and on routine electrolytes was found to have hypokalemia. So before going into the discussion, I want to highlight few things where there are the few drugs that can cause hypokalemia. Like for example, in a patient with diabetic ketoacidosis, when you put them on insulin infusion, they go into hypokalemia. So there are certain drugs that can cause and certain states that can cause hypokalemia. That is like beta agonists, like non-selective beta agonists. Mostly beta agonists can cause hypokalemia. Insulin infusion can cause hypokalemia. Theophylline can cause hypokalemia. Caffeine can cause hypokalemia. These drugs are very important, and even alkalosis can cause hypokalemia. So you need to keep this in mind when you are evaluating a case of hypokalemia. In this case, patient has salbutamol nebulization that can cause hypokalemia. Like that in DK case, insulin infusion can cause hypokalemia. So you need to remember these things where patient can be prone into hypokalemia due to sudden shift from the external to the extravascular space to the intracellular shift of the potassium. So this is one such case where salbutamol nebulization can cause hypokalemia. The major things you need to remember: salbutamol, insulin therapy is the most common things we see in our day-to-day practice, which can cause then theophylline is one more thing that can cause. So these are the things you need to remember when you are dealing with the hypokalemia that can cause. The other drugs that can cause renal loss of hypokalemia, I'll explain them later in the later case discussion. A 35-year-old female presented to emergency with quadriparesis. On examination, she has tremor and neck swelling. So this is one more thing. So 35-year-old female, she presented with quadriparesis. Maybe when the patient has quadriparesis, you think neurologically and also some electrolyte disturbances are possibility. So since we already know this is a case of this discussion is about hypokalemia, you might have thought this is a case of hypokalemic paralysis. So when do you call it hypokalemic paralysis, and when do you call it hypokalemic periodic paralysis? So hypokalemic periodic paralysis, anything if it is occurring periodically, like it happened 2 years ago, it is occurring again, like once in 1 year or once in 2 years, occurring periodically, it is occurring recurring periodically, it is occurring. It is called hypokalemic periodic paralysis. So hypokalemic periodic paralysis can be n number of causes. That can be due to channelopathy. There are two kinds of hypokalemic periodic paralysis secondary to channelopathy. One is type 1, which is due to the calcium channel mutation. Type 2, which is sodium channel mutation. So they both are aggravated by carbohydrate meal. And there are secondary causes of hypokalemic periodic paralysis like thyrotoxic periodic paralysis. So this patient, where the patient has tremors and neck swelling. So this is a case of hyperthyroidism. Maybe hyperthyroidism might present as thyrotoxic periodic paralysis. This is a case of thyrotoxic periodic paralysis or thyrotoxic hypokalemic paralysis. So sometimes hyperthyroidism, some endocrine disorders can also cause hypokalemia that can present at like this. So this is one such example where hyperthyroidism, the patient has tremors, neck swelling. So that is suggestive of hyperthyroidism. Quadriparesis due to the hypokalemia. So the case of thyrotoxic paralysis, thyrotoxic hypokalemic or thyrotoxic periodic paralysis, it is occurring periodically. A 42-year-old male is known farmer. He is working in the farm in the afternoon, came back home and developed muscle weakness. So one of the most common things is when you are evaluating on an OPD basis, you look for a very classic, history is very important. Like you directly straight away go into the evaluation of urine electrolytes, ABG, everything, renal tubular acidosis and all. Before that, there are simple things that can cause hypokalemia. That is, any patient who is cancer patient or who is having normal decreased intake of food can cause into hypokalemia. Like some is chronically malnourished patient, some persons who are not eating well, they can go into hypokalemia due to poor intake. Always the dietary supplementation is good enough, is always needs to be taken. Especially in this case, the patient is a farmer working in the afternoon in the farm, so there will be increased profuse sweating especially during the summer session. They can go into the hypokalemia. So these all need to be taken into the consideration before going into the organic causes like any renal causes. Before evaluating them, you need to look at the small causes where the patient can have hypokalemia. So these are all very important in the case of hypokalemia evaluation. So you need to ask whether the patient is taking proper dietary history or not, whether the patient is going into recurrent hypokalemias. So you need to ask all the dietary history, whether it's taking proper food that can supplement the dietary potassium. Dietary potassium at least require 80 milliequivalents. That is very important. So in the patient is working in the profuse sweating, so they can also cause hypokalemia. So this is one more cause that needs to be remembered when patient is evaluated for hypokalemia. So this is a 23-year-old female presented with vomitings 10 episodes per day and was found to have metabolic alkalosis and ABG and also hypokalemia. So all know when a patient is having GA, there are the GA loss of hypokalemia. These are also like these things we miss. The GA losses, sweating causes, decreased intake. These all and other drug related like beta agonists and also insulin infusion. We'll miss these causes before we straight away go with ABG and electrolytes. So we need to evaluate these also. The patient is having vomitings because of the acid loss. The patient will have hypokalemic, hypochloremic, metabolic alkalosis with paradoxical acidosis, which is a classically seen in pyloric stenosis. It also seen in the vomitings also. The patient has metabolic alkalosis, the patient will have hypokalemia, hypochloremia. So this is a case of vomiting related hypokalemia. So the GI also needs to be kept in mind when you are evaluating the cause of hypokalemia. So they are also very important in evaluating the hypokalemia. So before going into the real cause, I want to summarize these causes so that you will remember them when you are evaluating the cause of hypokalemia. Case 5. A 30-year-old male is presented to OPD with nephrocalcinosis and evaluation patient was found to have ABG of mild metabolic alkalosis. There is also hypomagnesemia and hypokalemia. In urine electrolytes, calcium excretion is increased. So this is one more thing. So this is an interesting case I have seen in my MD residency where the patient has nephrocalcinosis. We wanted to know what is the cause of nephrocalcinosis per se. There are very few causes of nephrocalcinosis per se. Any channel, but distal RTA can cause nephrocalcinosis. Any Bartter syndrome can cause nephrocalcinosis. Any proximal RTA like dense disease, especially proximal only dense disease can cause nephrocalcinosis. Any sodium phosphorus defect can cause, and also any pyelonephritis or oxalosis, they can cause nephrocalcinosis. But there are very few numbered causes of nephrocalcinosis that can cause significant medullary nephrocalcinosis. In them, one of the most common things is, in this case, you find nephrocalcinosis. You will check for any distal RTA is present. Distal RTA is one common cause of nephrocalcinosis. ABG is only, there is no estrus, there is mild metabolic alkalosis. So this might be a case of Bartter syndrome. Bartter syndrome is a possibility, urine calcium is increased, but patient has hypomagnesemia also. Generally, Bartter syndrome, the magnesium will be generally normal. So this might not be a case of Bartter syndrome. So other possibilities, dense disease will have other electrolyte disturbances also. So like generally of all the electrolytes, I will also add on a point here, of all the electrolytes, the only magnesium is the only electrolyte which is majorly absorbed in the thick ascending lobe. Other all electrolytes are absorbed in the proximal. PCT is the major site of absorption except the magnesium. Magnesium is absorbed in the thick ascending lobe. So this case on evaluation was found to have Claudin defect familial hypomagnesemia. So Claudin defect that is causing hypomagnesemia, hypocalcemia and hypercalcemia. So what happens is there is a transcellular channel called Claudin which allows calcium and magnesium absorption in the thick ascending lobe. So if there is a defect in the Claudin, it causes hypomagnesemia, hypocalcemia with hypercalciuria. That is causing nephrocalcinosis. They might have mild metabolic alkalosis also. So this is the case of Claudin mutation, familial hypomagnesemia. So one more thing why I want to highlight this is a patient is having hypomagnesemia. That might be, this is an interesting case, that's why I kept it. So any patient with hypokalemia who is refractory should always check for hypokalemia, because hypokalemia will inhibit we should always check for hypomagnesemia. All cases of hypokalemia, if they are refractory, you should check for hypomagnesemia, because hypomagnesemia will inhibit ROMK channel, that will in turn cause potassium loss in the urine. So always, all the cases of hypokalemia, you should always check for hypomagnesemia if they are not improving. So here hypomagnesemia is causing hypokalemia, but what is the cause of hypomagnesemia? That is secondary. That is due to, in this case, because nephrocalcinosis is there, metabolic alkalosis is there, patient is having calcium loss. That is due to the Claudin mutation. That is one of the very interesting cases we have seen in our MD residency. That is Claudin mutation is one where the patient have familial hypomagnesemia. So you need to remember the cause of nephrocalcinosis. That is one thing. Nephrocalcinosis is caused by oxalosis, pyelonephritis. In any channel, distal RTA is one cause, dense disease is one cause, Claudin mutation is one cause, and Bartter syndrome is one cause. So these are 4 or 5 causes that can cause nephrocalcinosis. You need to remember them. So where there is a loss of calcium more. So then a 25-year-old female presented with complaint of weakness and a history of similar complaints in the past 1 year ago. And ABG has metabolic acidosis, which is normal anion gap, and the patient has renal stones. So this is a 25-year-old female. Unlike in the previous case, the patient has similar complaints in the 1 year ago. There is one more episode previously, and ABG has metabolic acidosis. So which is normal anion gap, patient has renal stones. So the patient has weakness mostly due to hypokalemia, metabolic acidosis is there. Unlike previous case where the alkalosis is there, here acidosis is there, which is normal. So any normal anion gap metabolic acidosis should always suspect renal tubular acidosis. So in that, patient has renal stones also. So generally in distal RTA we generally see renal stones. In generally proximal RTA we generally don't see much of renal stones, because the acidosis is not significant in proximal RTA to cause bone resorption and cause calcium excretion in the urine. So in proximal RTA also we see mostly in the dense disease we see, but other causes we generally don't see in the proximal RTA, the renal stones. Distal RTA is the most common cause of renal stones. So this case, since the patient has metabolic acidosis, normal anion gap, this can be RTA. Whether type 1 or type 2 is secondary. Type 1 have more significant acidosis, urine pH is on the more side, there is renal stones at presentation. So a more significant hypokalemia will be there in the distal. Whereas in proximal, hypokalemia is not significant, acidosis is also not significant, there won't be much of stones also. And also the patient will have more other also, there is glycosuria, proteinuria, all other things will be there in proximal RTA. Since there are renal stones, there is significant acidosis, there is significant hypokalemia, this might be a case of distal RTA. So always RTA is also should be kept in mind when you are evaluating case of hypokalemia. A 24-year-old female has multiple renal cysts and also has presented to emergency with muscle cramps, and an evaluation was found to have a metabolic alkalosis. So this is one more thing. So what is the cause of renal cysts, you think? So like in hypokalemia, what will happen is if the patient is having hypokalemia significantly, there are certain complications of hypokalemia. Hypokalemia patient develop renal cysts. So renal cysts are one of the complications of hypokalemia. So you find in patients, when you look for the hypokalemia patient, if they're chronically hypokalemic, you find cysts in the ultrasound. So they might have cysts that is due to the hypokalemia. And also there are in the chronic complication you will have chronic tubulointerstitial disease also. They might have nephrogenic diabetes insipidus also. These are the chronic complications of renal hypokalemia per se. So they might be going into CTID, they might be having renal cysts, they might be having the nephrogenic diabetes insipidus. These are the chronic complications of hypokalemia. And hypokalemia is one of the risk factors for the patient going into persistent hypokalemia is one of risk factor that the patient is going into CKD, that is CTID related CKD. So that is also a possibility. So here patient is having muscle cramps. So hypokalemia can present in the n number of forms. One of the most forms we see in our day-to-day practice is quadriparesis. Other forms is erythemia, any U wave presentation, paralytic ileus, constipation, and muscle cramps. And also one of the rare presentation is rhabdomyolysis, where the patient with hypokalemia and also hypophosphatemia is one of the most common cause of rhabdomyolysis. So here patient is having muscle cramps, you should always look for the rhabdomyolysis in this patient. So rhabdomyolysis is one of the rare presentation of hypokalemia, so that is also a possibility in this case. So the patient has hypokalemia, patient is having chronic hypokalemia, we don't know what is the cause, patient is having metabolic alkalosis. So we know when we are looking for the metabolic acidosis, we look for the renal tubular RTA as a cause. When the patient is having metabolic alkalosis, you look for the two things, whether the patient is having hypertension or no. If the patient is having hypertension, you look for the aldosterone related causes and all. If the patient, they didn't mention anything, we are thinking it is normotensive patient. Then the most common possibility is either Bartter syndrome or Gittelman syndrome. So generally Bartter syndrome will generally present at very young age, antenatally or neonatally. Only one form of Bartter syndrome present at elderly, that is type 3. Other forms all present very early in the neonatal. So generally any 20 to 30 adolescent age that is presenting with metabolic alkalosis and hypokalemia, that is most commonly have Gittelman syndrome. They have associated hypomagnesemia also. That might be one of the cause of muscle cramps also. If you check them, they have hypomagnesemia. There is no significant calcium loss per se. They have hypomagnesemia per se. Why is the mechanism? I will explain in the later slides when I am coming. So this might be a case of Gittelman syndrome because of the age of presentation, because Bartter is generally present in infancy, whereas Gittelman is more of adolescent presentation. And metabolic alkalosis with normotensive, there are only two possibilities, either Bartter or Gittelman is the most possibility. Otherwise diuretics is also, thiazide diuretics is also possibility, but they didn't mention anything about diuretic history. If diuretic history is there, then we can think of thiazide diuretics or any diuretic history can be a cause. So coming into the discussion of diuretics, we should always think that thiazide diuretics are more potent to cause or loop diuretic are more potent to cause hypokalemia. So generally thiazide diuretics are more potent to cause hypokalemia when compared to loop diuretics. So why is that mechanism? You read about it and let me know why loop diuretics are doesn't cause significant electrolyte disturbances, where thiazide diuretics are more potent in causing hypokalemia. You read about it and let me know. So one more thing, that is thiazide diuretics can cause hypokalemia. That if the metabolic alkalosis normotensive is there, either Bartter's or Gittelman. Bartter's is more infancy, Gittelman's is more of adolescent presentation. If diuretic is there, thiazide diuretics is also a possibility in this case. A 54-year-old male who have persistent GERD presented to OPD with complaint of constipation, and an evaluation was found to have hypokalemia. So he is just having GERD. So all GERD patient in our OPD basis generally take proton pump inhibitors. So what is the importance of this? So any patient who is taking proton pump inhibitors for the long time, they are prone to have hypomagnesemia because of the chronic acid suppression. They have chronic hypomagnesemia. Because of that hypomagnesemia, patient will have hypokalemia. So that is the cause of constipation. So this is one more thing. The drug history was also important in this way. So any patient who is having PPIs, that patient who is taking barium supplements or something, any barium minima, something, they are all prone to have hypomagnesemia. Like some patients who is having esophageal cancers and all. So in that patients also, the patient who is taking cisplatin therapy, especially some chemotherapy like cisplatin therapy, they are prone to have hypomagnesemia. Hypomagnesemia can cause hypokalemia. So in them, the hypomagnesemia and hypokalemia should be corrected. So always drug history related to hypomagnesemia that can cause hypomagnesemia should also be asked for. Like drugs that can cause hypomagnesemia are most commonly PPS can cause, barium supplementation can cause, cisplatin can cause. So these all need to be kept in mind when you are looking for the cause of hypokalemia. So in this case, the PPAs we are using that can cause hypomagnesemia, that cause a decreased magnesium absorption, that in turn can cause hypokalemia. So this is one of the such interesting case where hypomagnesemia secondary to some drug can cause hypokalemia. This can be similar case in the esophageal malignancy where we are using cisplatin, where the patient can develop hypomagnesemia and hypokalemia. A 30-year-old male has history of watery diarrhea and is having muscle cramps and has UAS on ECG. So this is, you like might be from the history you might have thought is the case of hypokalemia. What is having watery diarrhea? So if you know watery diarrhea, hypokalemia, you might have thought this is a VIPoma case. So VIPoma is one of the it's a neuroendocrine tumor that can be present in the pancreas or duodenal region, where it can secrete the neuroendocrine hormones, where it can cause watery diarrhea and all hypokalemia. So in that patient, the patient will have hypokalemia. This is one of the neuroendocrine tumor, can also VIPoma, especially where the vasculointestinal peptide is being secreted. That is the most, VIPoma is the common cause where water diarrhea, hypokalemia and metabolic acidosis presentation where the patient will have that. So VIPoma is also a possibility in this case. In them, how do you differentiate between the renal tubular acidosis and VIPoma? Both will have acidosis in the presentation. So then you look for the urine osmolar gap. What is urine osmolar gap? Na minus K plus Cl minus, Na sodium minus potassium plus chloride is urine osmolar gap. Generally, urine osmolar gap is generally positive in the case of distal arteria, where it is normal in the case of GI losses. So that is one more thing that will differentiate between the whether metabolic acidosis due to the VIPoma or due to the renal tubular acidosis. So that is one more possibility in this case where urine osmolar gap can be used as an inference, where urine osmolar gap is positive in the case of renal causes, where urine osmolar gap is normal in the case of GI losses. Case 10. A 24-year-old male has recurrent episodes of quadriparous attacks are prescribed by carbohydrate meals and has hypokalemia, intermittent potassium is normal. So this is a classical history of channelopathy where the patient because of the carbohydrate intake they'll have hypokalemic episode. Intermittently they have normal. So the classical history will be they'll be going for some outside meals for lunch or something, they'll eat excess amount of rice or something, they'll present with quadriparous, they'll have hypokalemia. So this is the hypokalemic periodic paralysis secondary to channelopathy. There are two kinds of hypokalemic periodic paralysis secondary to channelopathy. One is sodium channel defect, the other is calcium. Type 1 is calcium channel defect, whereas type 2 is sodium channel defect. So type 1 is a calcium channel defect, type 2 is a sodium channel defect. They have classical history of aggravated by carbohydrate meals. So they generally have proximal muscle weakness classically. If their episodes keep occurring, they will have persistent proximal muscle weakness also. So this is one more thing I want to highlight, where quadriparous is aggravated by carbohydrate meal is generally seen in channelopathy, where type 1 is calcium related, type 2 is sodium related. So they are managed with the potassium supplementation, they will recover intermittently, they are generally normal. A 30-year-old male present with hypertensive emergency to a hospital and has hypokalemia and alkalosis. So a patient has hypokalemia, alkalosis, hypertension. So we all dealt with normokalemia, then we dealt with acidosis where RTA is a possibility, normotensive where the alkalosis is a possibility, discussed with Bartas and Kittelmans and thiazide diuretics. Now we are coming into the hypertensive. So hypertension we took for, again, generally hypertension is generally associated with alkalosis only mostly. So generally hypertension, alkalosis is there, they have hypokalemia and alkalosis also. So there are two possibilities. So in this case, let's say the patient has high aldosterone and low renin. So high aldosterone and low renin is generally and the second possibility is high renin and high aldosterone. So I'll give you an example. So first example is the patient is having a adrenal mass, that patient is having hypokalemia, alkalosis and hypertensive emergency. That is a case of Conn syndrome. Conn syndrome secreting aldosterone. That is a possibility where the patient is having high aldosterone and low renin and is having hypokalemia and alkalosis and hypertensive emergency because of the aldosterone secreting tumor. So if there is a high aldosterone and low renin, you suspect the aldosterone producing tumor, that is Conn syndrome. One more possibility is familial hyperaldosteronism type 1, where generally the aldosterone is not under the control of ACTH. In some cases, where the cause is that familial hyperaldosteronism type 1 or glucose remediable hyperaldosteronism. So in those both cases, the both are same terminology, two different names actually. FH type 1, that is familial hyperaldosteronism type 1, or glucose remediable hyperaldosteronism, or glucose remediable hypertension. So where the cause is because the aldosterone comes under the regulation of ACTH in these cases. So because the treatment is steroids in them, because generally ACTH doesn't control aldosterone. Aldosterone is on the control of potassium levels and the fluid levels in the body. In these cases where FH1 and glucose remediable hyperaldosteronism, in this case the aldosterone comes under the control of ACTH. So in this case the treatment is steroids. You suppress the ACTH, aldosterone will come down. So in this FH1 or aldosterone familial hyperaldosteronism type 1, the treatment is steroids. In the case of aldosterone producing tumor, the treatment is you remove the tumor and all. So that is the cause of high aldosterone low renin ratio. So one is high aldosterone lower, one is the aldosterone producing tumor, that is very clear. Second is glucose remediable hyperaldosteronism, the FH type 1. So in that the ACTH controls the hyperaldosterone, in them aldosterone is increased, so it gives steroids, the ACTH is suppressed, aldosterone is also suppressed. So that is one possibility. The second possibility in this case, if the patient has high renin and high aldosterone, so both renin and aldosterone are very high. So in that the possibility is, if you get a renal artery Doppler in those cases where high renin and high aldosterone is possibility, the possibility is renal artery stenosis. Renal artery stenosis can cause high renin and high aldosterone because there is decreased perfusion to the kidney per se. It causes increased renin and also increased aldosterone also. So RAS is a possibility. Renin aldosterone RAS, renal artery stenosis is a possibility. Second possibility is, especially in the pediatric case, infancy, the renin secreting tumors, where renin is increased in the case of, because of renin secreting tumors is also a possibility where they secrete renin in turn stimulates aldosterone. So that is also a possibility, especially in the pediatric cases. Otherwise, in the adults, RAS is the most common possibility in such cases. So case 12. A 32-year-old female present with excessive weight gain, striae and hypokalemia, impaired sugars to OPD. So in this case, excessive weight gain is there, striae is there, hypokalemia is present. So this is classically a case of Cushing syndrome. You can see excessive weight gain, striae, hypokalemia. So sometimes if the excessive cortisol is present in the body, where the patient will have they don't have much of aldosterone elevation, they will have cortisol elevation. So in that patient, cortisol will act on the mineralocorticoid receptor also when it is present in excessive mode. So Cushing syndrome also needs to be ruled out when the patient is having hypertension, especially obese, striae, proximal myopathy, easy fatigability, easy bruisability, where the classical symptoms of Cushing syndrome is present. Hypokalemia, hyponatremia is there in them. So in them you should always look for the Cushing syndrome. So this is the case of Cushing syndrome. You get a dexamethasone suppression test, the cortisol won't be suppressed less than 1.8 micrograms per deciliter. How do you do this test? I will discuss on the Cushing syndrome. But you need to remember, Cushing syndrome is also a cause of hypokalemia. So a 27-year-old male presented to OPD with complaints of hypertensive urgency, and an evaluation, renal Doppler is normal, hypokalemia and all closes are present. So aldosterone is low and renin is also low. Similar history in the father. So how do you tell about the cases? So same hypertensive urgency is there, renal artery Doppler is normal, so hypokalemia is there, alkalosis is there, so aldosterone is low. So there is aldosterone is low, but hypokalemia, generally if aldosterone is low, generally hyperkalemia should be there. But aldosterone is low, hypokalemia, alkalosis is there. So there is something that is activating ENaC mutation or mineralocorticoid receptor mutation. So that is a possibility, and renin is also low. Both are subject. So that's why there is generally the receptor effect or ENaC channel mutation is there. But similar history in the father is there. So it is generally, if the similar history is there in the father, that is an autosomal dominant inheritance. Because from father it is directly inheriting, it is mostly autosomal dominant. So second generation is affected, autosomal dominant. So this might be a case of Liddle syndrome. Liddle syndrome is an autosomal dominant. Patient will have low aldosterone, low renin. They have activation of ENaC or mineralocorticoid receptor gene, where they directly activate, they have activating mutation. Because of that, there is a hypokalemia and metabolic alkalosis along with low aldosterone, low renin, and also have hypertension. And they have autosomal dominant inheritance. That is a case of Liddle syndrome. But similar case, a 27-year-old male presented to OPD with complaint of same hypertensive urgency, and evaluation renal artery Doppler is normal, hypokalemia and alkalosis are present, but aldosterone is low and renin is low, but no family history and cortisol is normal. So there is no family history. So what is this case? So this case is mostly, so there is no family history. So in this case might be same, aldosterone is low, renin is low, cortisol is normal. This might be a case of syndrome of apparent mineralocorticoid excess. Generally, cortisol is metabolized by 11-beta hydroxysteroid dehydrogenase. So if there is a defect in the 11-beta hydroxysteroid dehydrogenase and the cortisol won't be converted into cortisone. So that cortisol will act on the mineralocorticoid receptor and function as the mineralocorticoid that can cause hypokalemia, metabolic alkalosis and hypertension. So here, because of the decreased, there is an enzyme deficiency of 11-beta hydroxysteroid dehydrogenase. So because of that, there is there is cortisol is not inactivated, that acts on the mineralocorticoid receptor, that is causing. Then this is autosomal recessive inheritance, so there is no family history. So this is autosomal recessive, most of them might be carriers. So this is autosomal. So Liddle syndrome is autosomal dominant, same picture, similar picture, the family history is different. So generally we do the genetic analysis for this, but the family history, this history also can play a role in this case. So that is one more thing I want to point out in this case. One of the licorice also inhibit the 11-beta hydroxysteroid dehydrogenase. Licorice consumption can also cause inhibition of 11-beta hydroxysteroid dehydrogenase, and present a similar case, normal renal arteries down, hypokalemia, metabolic calculus, and hypertensive urgency. Aldosterone and renin will be both below. This is the same case. The same case, a 27-year-old male present with hypertensive urgency and an evaluation renal artery Doppler is normal, hypokalemia and alkalosis are present. Aldosterone is high to normal and renin is low. In this case, aldosterone is high to normal. In previous case, aldosterone is low and family history is present in mother and grandfather. So there is autosomal dominant history. This is a case of glucocorticoid remediable hypertension. Glucocorticoid remediable hyperaldosteronism also is a possibility. The same case, FH1 type 1, first thing, and then the previous case we discussed aldosteronism, the same case, AAC series, the same case in this case. This is glucose remediable hypertension or glucose remediable hyperaldosteronism. So this is because of the ACTH controls the aldosterone production also. If it is FH1, it is a familial hyperaldosteronism type 1. In this we give steroids that will control the hypertension and control the hypokalemia. Even in the same also, even separate syndrome of apparent mineralocorticoid excess also, we give steroids only, because cortisol is the one which is excessively produced. We give the same steroids that will suppress the cortisol. So cortisol will be suppressed, so that we will have a normotension. A 60-year-old female with splenomegaly has platelet count of 12 lakhs, has hypokalemia. What is this? So any thrombocytosis, any leukemia, any elevated blood counts can cause pseudo-hypokalemia. So why it causes pseudo-hypokalemia is your homework. Read about what is the cause of why it causes pseudo-hypokalemia and get back to me. So all elevated cases of leukemia, essential thrombocytosis, polycythemias, they can have pseudo-hypokalemia. So all leukemias, if there is hypokalemia, you should label it pseudo-hypokalemia. True hypokalemia, generally if you want to check if there is true hypokalemia, you should send sample immediately or get it in the ABG format. Then you'll know if the true hypokalemia is present or not. Generally, anywhere related platelet count, thrombocytosis, leukemias can have falsely low potassium. What is the cause? You'll read about it and let me know. So that is the discussion. So hypokalemia, if it is less than 3.5 millimoles per day, that is when we label it as hypokalemia. If it is emergency, you go ahead for therapy and don't wait for the evaluation. First you rule out pseudo-hypokalemia where there is thrombocytosis or leukemia causes are there. So that is a possibility, you need to rule out them. Then if it's pseudo-hypokalemia, no need to further work up. In order to label it, if you want to rule out in the case of pseudo-hypokalemia, it is generally hypokalemia is present or not, just send a fresh sample, immediately get a high potassium done, then you will know if it is a true hypokalemia or not. If then also fresh sample is hypokalemia, maybe that is a true hypokalemia. So then you get for history and physical examination, like in my MD I have seen a case of where patient has persistent hypokalemia and the patient has dryness of eyes and all. So it is a case of Sjogren syndrome with distal RTA. So that is one of the most interesting cases I have seen in my first year residency. So on the evaluation and because of the dryness of, we thought this Sjogren's is there, we sent anti-ro that is positive, then we came to diagnosis of Sjogren syndrome. So then you send urine potassium. So urine potassium generally anything less than, that is 24-hour thing, 24 less than 50 millimoles per day or less than 50 millimoles per gram per creatinine. So if it is less than 50 millimoles per day or less than 50 millimoles per gram per creatinine, so is extrarenal. Anything more than 15 is renal loss. So then if it is renal loss, you get for TTKG. If it is extrarenal loss, you just get acid based analysis. Before ruling all of this, you look for other causes like insulin excess or beta-2 adrenergic agonist or any hyperthyroidism, any barium intoxication, theophylline, chloroquine. So these all needs to be ruled out. So these are all the causes where the drugs can cause hypokalemia because of the shift from the extracellular fluid to intracellular fluid. So these all need to be ruled out. So after that, if the extrarenal cause is there, you check for acid-base balance. If metabolic acidosis is there, it is GI loss. If it is normal, there is no acidosis or something, it is a profuse sweating like we discussed in the farmer case. If it is metabolic alcoholism, sometime in the past there is vomiting or something, some diuretic usage or profuse sweating sometime can cause metabolic alcoholism because of the bicarbonate loss. So that is a, if you are putting NG tube also can cause metabolic alcoholism and potassium wasting, especially who are put on the long-term NG tube, you continuously aspirate that patient, no? That is a cause. When coming into renal causes, you get a TTKG. For TTKG, you require serum osmolarity, urine osmolarity, serum potassium and renal potassium, urinary potassium. So in that, if TTKG is more than 4, it is a distal potassium excretion. If it is less than 2, mostly due to the osmotic loss. It is due to the increased tubular flow because of the complete, like in the case of post-AK diuresis, will the renal loss, will the ATN recovery phase where there will be diuretic phase, no? Like that. Just there is osmotic diuresis just because of the excessive fluid loss in the tubular flow in the per se. If it is more than 4, distal RTA is a possibility, but the concept of TTKG is called into question in the recent time, whether we should really use it or not, because it is not per se very reliable, because it varies from the hypokalemia serum value, so it is not very reliable per se, so it might not be, the guidelines might change in the future where TTKG might not be used in the future. So if TTKG is more than 4, distal potassium excretion is a possibility. Then you check for BP. If BP is low or normal, you check for the ABG. ABG is acidosis present, so it is a proximal RTA or distal RTA or some diabetic ketoacidosis, or amphotericin B acetozolamide also causes RTA. By they act at the tubular level only. They cause distal or proximal RTA. So that is how they cause the metabolic acidosis. So when compare the patient, say normotensive patient have metabolic alkalosis per se, you check for urine chloride levels. If urine chloride levels are more than 20, so if urine chloride is less than 10, then generally most of the trial is a diarrhea or GI causes. If urine chloride is less than 10, if urine chloride is more than 20, so then you check for urine calcium creatinine ratio. Generally calcium is lost in the case of Bartter syndrome. It is not lost in the case of Gittelman syndrome. So if calcium is lost more, urine calcium creatinine is more than 20, where calcium loss is there, that is a Bartter syndrome or some loop diuretic. If calcium or chloride is less than 15, that is Gittelman syndrome. Thiazide also acts like the Gittelman's law, that is Na plus chloride channel defect. So based on calcium and creatinine ratio, calcium is mostly lost in Bartter syndrome and loop, Na plus that is thick ascending loop. Whereas calcium is not, there is no hypercalcium in Gittelman syndrome or thiazide diuretics. So that is less than 0.5, it is labeled as calcium creatinine. So generally chloride loss is generally urine chloride is less than 10 in GI causes, and more than 20, then you look for these causes. So if BP is more, then you check for aldosterone. If aldosterone is per se high, then you check for renin. Renin is also high, then renin artery stenosis or renin producing tumor or some malignant hypertension is a possibility. If renin is low, then it is an aldosterone secreting tumor or familial hyperaldosteronism type 1, that is ACTH controlling glucose remediable hyperaldosteronism, that is one possibility where ACTH controls the aldosterone, where you give steroids. If aldosterone is low, then you check for cortisol. Cortisol is high, Cushing's. Cortisol is normal, then Liddle syndrome, where low aldosterone, low renin, the cortisol is normal, where there is autonomous activation of ENaC channel is present. So there is a familial autosomal dominant inheritance is also there. Then if the patient has no ignored family history, there is autosomal, similar picture, autosomal recessive is there, then it is called syndrome of apparent mineralocorticoid excess because of the 11-beta hydroxysteroid dehydrogenase mutation, where there is no inactivation of cortisol to cortisone. In them you give steroids, so cortisol will decrease, hypertension also will decrease. So licorice also inhibits the 11-beta hydroxysteroid dehydrogenase only. So same only will present. But same is autosomal recessive, it doesn't have significant family history. So these are the various drugs that can cause hypokalemia, like ampicillin, penicillin, amphotericin B, aminoglycos. They cause renal potassium lights at the tubular level. So beta-2 receptor agonists like the salbutamol, the all beta-2 agonists we can use. Does beta-1 antagonists like metoprolol, do they cause hyperkalemia? Because reverse should occur, no? But generally they don't cause, like metoprolol and this on don't cause hyperkalemia because it is mostly due to the beta-2 effect. It is non-selective beta blockers can cause hyperkalemia, but beta-1 selective beta blockers generally doesn't cause hyperkalemia. It is beta-2, mostly beta-2 that is causing the hypokalemia, potassium influx into the cells. So diuretics like acetazolamide, furosemide, metazone, all thiazide diuretics can cause, insulin can cause, mineralocorticoids, laxative can cause, and theophylline and caffeine can cause, verapamil can cause, like verapamil can cause shift. The same, the most important is diuretics you need to remember, some beta-2 receptor, insulin should be remembered, and any PPIs that can cause, PPIs or cisplatin or any barium minimus, they all need to cause, they can cause hypomagnesemia, that can cause hypokalemia. They all need to be remembered in that when you are evaluating hypokalemia. As I mentioned, FH type 1, it is due to 11 beta, say CYP11B1 mutation where a hybrid gene is present. So in that case, where the ectopic expression is there, regulated by ACTH. ACTH controls the zona fasciculata region also, that can be remediated by where ACTH is controlling the aldosterone levels also in the body. So that is relieved by giving the steroids. In the treatment is glucose remediable hyperaldosteronism, where you give treatment is steroids. So where the patient will have high aldosterone and low renin and metabolic alkalosis is present, hypokalemia is present. So these are familiar FH type 2, other we will discuss in the when we are taking endocrine other causes of the, what are the FH type 2, type 3, type 4. I will discuss when I am taking my endocrine causes. Now they are not required. So these are various channelopathy. Like I mentioned, hypokalemic periodic paralysis type 1 is due to the high calcium channel defect, whereas type 2 is due to the sodium channel defect. There are other channelopathies also. Chloride channel, it can cause myotonia congenita. So myotonia is anything like like a small little contractures, like small spasm like thing, that can have various variants. I'll discuss about the, I think rather than telling it in theory based, I'll put a proper case based approach to explain these channelopathies per se. And potassium channel defects can cause Anderson's disease, where you have long QT and they can go into the sudden cardiac death also. That's due to KC and J2 mutation. So these are things. But in this case scenario, you need to remember hypokalemic periodic paralysis type 2 is due to sodium channel. Hypokalemic periodicis type 1 is due to the calcium channel. So that mutation in sodium channel is SCN4A and calcium channel is CNCA1S. So these are needed. Remaining that I will explain the channel of this topic. So these are the different types of Bartter syndrome: type 1, type 2, type 3, type 4, type 5. Type 1 and type 2 are generally present at antenatal age. They have polyhydramnias, polyuria, polydipsia. They generally don't survive till the birth also. They are generally autosomal recessive. They are present at antenatally only. They don't survive. The type 3 is the classical present in the adolescent age. Presents as Gitelman syndrome. They also have polyuria, polydipsia, failure to thrive symptoms. And they resemble Gitelman's. But type 1 is due to the Bartle mutation. Type 1 is due to the sodium potassium channel mutation. Type 2 is due to ROMK mutation. Type 3 is due to the chloride channel basolateral mutation. Type 4 is Barton mutation. So type 4 Barton mutation will have sensory neural hearing loss also. Same present polyuria, polydipsia, failure to thrive is a common reason. Type 4 will have sensory neural hearing loss. Type 4 is a calcium sensing receptor, where the patient will have polyuria, polydipsia and nephrocalcinosis and hypomagnesemia. So this is the same present as Claudin mutation. Similar to the Claudin mutation, this also can cause high nephrocalcinosis. So type 1 and type 2 generally don't survive till adulthood. Type 1 is due to the sodium potassium channel, chloride channel, potassium chloride channel mutation, whereas type 2 is due to the ROMK channel mutation. They generally don't survive also. They are present antenatal with polyhydramnias, failure to thrive. Type 3 is due to the adult presentation, which is a classical Bartter's and which is a autosomal recessive and resembles Gitelman's mutation. Type 4 is Barton mutation, where they have sensory neural hearing loss and is also mostly present at antenatal only. Type 4 is neonatal, where they have nephrocalcinosis and hypomagnesemia is possibility, which is a calcium sensing receptor mutation. And this is the only type 5 is the only autosomal dominant, with all are autosomal recessive. So these are the difference between classical Bartter and Gitelman. Bartter is due to the thick ascending loop. Gitelman is a sodium channel. Gitelman is generally present at adolescent, whereas classical Bartter is generally present early childhood or infancy. We discussed most of the cases are present in antenatally or infancy. And maternal hydramnias, polyhydramnias is a possibility in the classical Bartter's in the type 1 and type 2, but generally maternal polyhydramnias is absent in Gitelman syndrome. Polyuria, polydipsia, we have seen all the cases of Bartter's have polyuria and polydipsia, it is absent in Gitelman's. Dehydration is very often in the case of Bartter syndrome, which is absent because significant fluid wasting is there in the case of Bartter syndrome. Tetany is also rare, but tetany is present in Gitelman syndrome because the magnesium is low. No? Magnesium will in turn affect potassium and calcium channel, that can cause tetany. So generally hypomagnesemia is more commonly seen in Gitelman syndrome. Only variant you see hypomagnesemia and significant in Bartter's is type 5 Bartter, which is due to CSR mutation. We usually see hypomagnesemia, hypocalcemia with nephrocalcinosis. And growth retardation is seen in the bladders because it is present at very young age, and childhood. Generally growth retardation is not seen in Gitelman syndrome. Urine calcium is normal or high because calcium is absorbed in the thick ascending loop with the paracellular pathway. It is high in the case of classical Bartter's. Generally urine calcium is low in the case of Gitelman. In the evaluation also we learned urine calcium creatinine ratio is high in Bartter syndrome and loop diuretics, low in the case of Gitelman's and thiazide diuretics. Nephrocalcinosis is rare but absent in the rare in the case present in type 5, absent in the case of Gitelman syndrome. Serum magnesium is occasionally low, except in the case, especially in the case of CSR type mutation. Generally low in the case of Gitelman syndrome because of TRMP5 mutation, because of the TBRMP5 mutation channel, which is helpful in the absorption of magnesium, is involved in the Gitelman syndrome mutation. So it is a hypomagnesemia seen in the case of Gitelman syndrome. So urinary prostaglandins, they are high in the case of Bartter syndrome. That is why indomethacin is used in the case of Bartter syndrome, not useful in the case of Gitelman syndrome. So this is one thing I want to highlight, where urine prostaglandins are high because after thick ascending loop you will have tubular feedback pathway. After that sodium chloride channel is there. So any electrolyte that is lost in the Bartter syndrome will be detected by TGF pathway. So after TGF pathway, macular densa is there, sodium chloride channel is there. So Gitelman after TGF, whereas TGF pathway activation occurs only, Gitelman is there. So when Bartter's electrolytes are lost, no, it is detected by macular densa and all, it will activate the prostaglandins. So prostaglandins are high in the case of Bartter syndrome. That's why indomethacin has some role. Whereas the macular densa are present prior to the Gitelman's channel. So when there is a loss from the Gitelman's channel, there is nothing to detect. There is no feedback pathway that will detect the loss after the Gitelman's sodium chloride channel. So generally urine prostaglandins are normal in the case of Gitelman syndrome. So generally high in the case of classical Bartter syndrome because TGF pathway is somewhere in between Gitelman's and Bartter's channel, so that it will detect the loss of electrolytes from Bartter's but cannot detect from the Gitelman's channel. So this is the different kinds of RTAs. This type 1 is a distal RTA where you find significant acidosis, whereas type 2 proximal generally you won't find significant acidosis there. And potassium is also usually very low, but type 2 proximal is generally not very low. There is mild hypokalemia. Type 4 is all hyperkalemia. Hyperkalemia and acidosis. And urine pH is generally more than 5.5 in the case of distal, whereas type 2 it is generally less than 5.5. And urine anion gap is generally positive, and nephrocalcinosis is more commonly seen in type 1 RTA, whereas rare in the case of proximal RTA. Only Dent's disease or Fanconi's we see proximal RTA. So one more thing we can confirm the distal RTA is by ammonia excretion test. Ammonia loading test is which we commonly use to confirm the presence of distal RTA. So that is the end of presentation. One more thing, for Liddle syndrome, we use amiloride for the use of eplerenone for the treatment of Liddle syndrome management. So you can give amiloride or something, ENaC channel inhibitor for the treatment of Liddle syndrome. So that is the Liddle syndrome.